Okay, thank you, everyone. I'm a PhD student from the University of Washington in the US. Today, on behalf of the entire study team, it is my pleasure to present updates on the assessment of bone mineral density from the ongoing PRIMA extension cohort study.
Move the slides on?
Yeah. Okay, so let's start with the study summary. The research questions that we asked is, does in-utero TDF-based oral PrEP impact bone mineral density, or BMD, among children at 36 months of age? What we have found is that there was no difference between BMD among children with and without in-utero PrEP exposure. Why is it important? In 2017, WHO recommended PrEP use among pregnant women at high risk of HIV based on data accrued from women living with HIV who use TDF-based ART during their pregnancy. However, as a preventive agent, the safety expectation for oral PrEP are really high. Previous studies show that lower than C-score and BMD among TDF-exposed neonates. However, it is unknown whether these differences are of clinical significance if persist into early childhood or if exist among women without HIV who use TDF-based oral PrEP during pregnancy. Therefore, WHO has called for continuous surveillance and longer-term safety evaluation among TDF-exposed infants. Our finding of no association between maternal PrEP use and infant BMD really boosts the safety profile of oral PrEP for pregnant women. Okay. There are only 2 studies that have directly measured the bone outcomes among TDF-exposed infants. Both of them are conducted in the SMART cohort among infants who exposed or not exposed to TDF-based ART during pregnancy. So the first study found that TDF-exposed infants had a lower bone mineral content, or BMC. The second study, however, didn't find any dose-response relationship between drug levels in meconium and BMC. A PrEP study found PrEP-exposed infant had a lower Z-score for length at 1 month and no difference at 1 year. However, the sample size for this study was small. So far, we found that limited data on bone outcomes among TDF-exposed infants. And there was also no studies that evaluated bone outcomes beyond the neonatal period and infancy. Few studies conducted among women taking TDF-based PrEP. Okay, so to fill this gap, we try to evaluate the association between in-utero TDF-based oral PrEP exposure and BMD at 36 months of age among mother-infant pairs in Kenya. So the parent study, here we go. So the parent study, which is a cluster RCT known as PrEP implementation for mother in antenatal care, offered PrEP to pregnant women living without HIV in 20 maternal child health clinics in Western Kenya. Participants will follow 9 months postpartum, and then the infant outcome from this study has been previously presented at IAS 2021, and my colleague, they are preparing this for publication. The extension study, PRIMA X, aimed to evaluate a longer infant safety outcomes, has completed the enrollment and is now actively following up participants. So mother-infant pairs are enrolled from 4 PRIMA facilities, include those clients who have complete the 9 months postpartum visit from the parent study, and a new client who start to use PrEP during pregnancy. Mother-child pairs were followed until 60 months postpartum. Birth and growth outcome were ascertained or measured by trained study nurses. About 40% pregnant women use PrEP during pregnancy. So we define in-utero PrEP exposure as any PrEP prescription during pregnancy and self-reported PrEP taking at a subsequent visit. A subset of singleton children aged 36 months with in-utero PrEP exposure was randomly selected and matched 1:2 to children without in-utero PrEP exposure on maternal age, maternal education level, and child sex and age. Whole body BMD was measured by dual energy X-ray absorptiometry or DEXA at Aga Khan University or AKU Hospital in Nairobi, Kenya. DEXA is a clinical standard to measure BMD. It is painless and non-invasive. The level of radiation is minimal, even lower than the natural radiation in a typical day. So in the picture on the right, as you can see, that's the DEXA machine that we use to measure children BMD at AKU. So children were brought to AKU by their caregivers and accompanied by study staff. Scans were conducted in duplicate due to the difficulty of young children being still during the procedure. And the average of the two scans were used for analysis. All scans were analyzed by a certified technologist, and then 50% were read by an external expert for quality control purpose. In the picture on the right, the radiology technician Brenda from the AKU was reading the DEXA scan for a child. So we used descriptive statistic to summarize the characteristic of the children receiving a DEXA scan. Linear regression adjusting for matching characteristic was performed to evaluate the relationship between BMD and in-utero PrEP exposure. Okay, so what did we find? In our analysis, we included 111 children receiving DEXA scan. 36% of them were PrEP exposed, 64% were PrEP unexposed. The age at DEXA scanning was 37 months, 40% were female. Maternal age at delivery was 28 years. Gestational age at birth was 38 weeks. PrEP use duration in pregnancy was 12 weeks. And then 95% mother initiated PrEP during the second and third trimester. Only 5% initiated PrEP during the first trimester. There was no difference in terms of the median height for children at DEXA scanning comparing children with and without in-utero PrEP exposure. There was also no difference in terms of median whole body BMD comparing children with and without in-utero PrEP exposure, which was about 420 milligram per square centimeter. The difference in average whole body BMD was also not different. Between children with and without PrEP exposure. So the difference was negative 21.6 milligram per square centimeter, and the p-value is 0.27. So we found PrEP exposure was not associated with BMD or height at 36 months among children with mother who used PrEP during pregnancy in this ongoing cohort. Our findings suggest that in-utero PrEP exposure may not impact BMD into early childhood. Moving forward, some next step for this bone evaluation project involve quantifying PrEP exposure during pregnancy using more objective measurements, such as measuring drug level using hair or drug blood spots. Our current analysis are using self-reported PrEP use as the exposure, which is a limitation. We are also currently conducting DEXA scan among the same group of children at 42 months and also among their mothers at both time points. And we hope to have the updated result to share in the near future. I'd like to thank our participants, PRIMA and PRIMA-X study team of founders. This work will also be presented in the session of strengthening sexual and reproductive health for diverse population at IAS on Tuesday at 4 p.m. If you are interested in our work, please come and talk to me. Thank you for your attention.